Now, we've talked at great length about pre-charging, the whole logistics of running a good resuscitation. But you also have to know your device. You've got to know how to pre-charge. You've got to know how to pre-charge. If you're not familiar with how to pre-charge the monitor and how to dump the charge, hook it up to the dose attenuator, the thing that you use to shake your monitor every morning, and practice pre-charging, and then dump the charge. Practice pre-charge and dump the charge. All right, so let's see what this looks like.
Pulse to CPR. 15 seconds left in the cycle.
Okay, I'm gonna pre-charge.
10 seconds.
10,
5, 4, 3, 2, 1.
hold CPR. That looks like, yeah, we're gonna shock it. Continue CPR.
8, 9, 10.
So it's pretty straightforward if we could just do that every single time. Not a big deal, right? Now, it looks like there was a bit of a lag from when they stopped CPR to when they defibrillated. That's the pre-shock pause. And it was because the CPR artifact was still on the screen. Once that stopped, they saw the VFib. But we have see-through CPR, so we could kind of anticipate that maybe a little bit more than they could. We really talked at great depth about minimizing pauses and ensuring efficient rotations. Now, this is ALS integration. So imagine that the fire department's on scene. What do? Do you connect the monitor immediately? Do you bump them off of CPR? What do you do? So imagine if you get on scene and the fire department has the AED connected and they say, hey, we defibrillated a minute 30. We're about to analyze again. Maybe let them analyze again, right? Why delay that? If in 30 seconds they're going to shock again or at least analyze again. Let them continue, get your monitor ready, and get someone on deck. All right, so let's see what this looks like.
6, 27, 28, 29, 30.
Just
Ventilations.
20.
Matt, how's it going?
Good.
What you guys at? 28, 29, 30.
One more respiration round.
Good ventilation.
We're gonna swap out so we can analyze it.
Okay.
After this respiration, Mario, you hop out.
20.
28, 29, 30.
Okay, and continue with compressions. After this cycle, we'll analyze.
Okay.
Remember, we'll hover while we analyze.
20. 6, 27, 28, 29, 30.
Okay, clear to analyze.
Clear of patient.
You want to hop out, Andrew?
Stop device. Stay clear of patient.
Hover.
Deliver shock.
Continue. Okay, we're going to switch
Great.
over to your machine.
Yes. Going for the VTI.
Okay.
30.
25, 26, 27.
After these
28,
ventilations, I'm going to have you
30.
go off to the right.
One.
The IV.
Yeah.
2.
Okay, slide off to the right.
So we're on our machine now. Good.
Okay. Okay, there's a good view there. Okay, tubes past the cords.
IV secured. 9, 30.
So what they did was pretty efficient for them and their crew configuration. For us, it's probably not going to work out the same. All right. Well, preferentially, you would have the paramedic move right in here, start getting the monitor ready, getting the pads out, getting your pads prepped, getting them ready to switch. And then I would let the person, the FD, the firefighter who's on the airway, continue to be on airway. Intubation should not be a priority. In fact, it's probably better to wait approximately 10 minutes to intubate in the first place. But just make sure they have an airway adjunct in, connect end-tidal, make sure you're monitoring end-tidal CO2. we shouldn't need the person that's on the monitor also controlling medications. All right, that should be an independent role. Monitor should be an independent role. If anything, the ALS provider, once they get access and they push the first medication, they push epi, well, they have time before they need to give any other medication. So why don't we bump them after they give that first medication to the airway and start getting prepped, right? Getting their tube holder behind the neck, getting their glide scope connected, powered on, getting their tube ready, styletted, getting all that ready to go, and then maybe they can give another medication at the direction of the person on the monitor and then come back up and secure the airway. Once that airway is secured, you can put the firefighter or police officer back on the airway, turn on your hand heavy, use your ventilation timer, and you don't need to worry about the airway, assuming that you have continuous waveform capnography. All right. Mechanical CPR devices, you know that our goal is that we do manual compressions for 10 minutes. We just do. All right. Because we've had a lot here recently, we've had a lot of long pauses with mechanical CPR. This was, and then we did competency on it. There should be 2 distinct pauses for mechanical CPR for adhering to the principles of high-performance CPR. The one pause to lift the patient up, slide in under the back plate, and then you connect the arm closest to you of the Lucas, and then you swing it over while they're still doing CPR. You swing it between their arms right here, all right? Then you connect it, and then when you're ready, you use your 2 fingers around the suction cup, 1 finger on the buttons, ready to go 1, 2, 3, or actually 2, 3. Number 1 should already be on. You pull it down, pause, start. All right, and hopefully you don't have to readjust it because the puck wasn't lined up to begin with, or you forgot to use the neck strap, so now the darn thing's moving down the chest. But there's no rush to put this on. Do it place it strategically in sequential steps around CPR, all right? And always be prepared. If something happens with the Lucas, your number 1 goal shouldn't be to troubleshoot that Lucas and figure out why it stopped or why it came disconnected. Your number 1 goal should be to resume CPR. And if you get rocks, if you get a pulse back, put the Lucas on if it's not on already.
Here you go, Becky.
8, 9, 10.
All right, let me know when you get that power unit ready.
Will do. Turn it on.
8, 9, 10.
All right, I'm ready.
Power unit's ready. You ready with the back plate?
Yes.
All right, in 10 seconds.
So you see how they're kind of rolling the patient, putting it under the patient's side. I think it's probably better to start with it under the head. And then on the count of the compressor, 1, 2, 3, lift the patient up, slide it under, and then lay him back down and resume.
Apply the Lucas device.
8, 9, 10.
5, 4, 3, 2, 1.
So I think that's a really inefficient way of placing the device. And at our resuscitation academy, Jonathan Larson, who was pretty much coined pit crew CPR, when they first got the Lucas devices, their survival rates decreased. So they got rid of them. And then a few years later, they decided, we'll try it again. And then they trained everybody. They spent a lot of time, effort, and money training everybody how to use the Lucas device. And then their survival rates didn't improve, and they saw a lot of long pauses, so then they had to take them off the trucks, do retraining, and then put them back on the trucks. So it's a big process to implement mechanical CPR devices efficiently, at least.
8, 9, 10.
Lucas set up.
8, 9.
So this is kind of the same thing. All right, special situations. So this is where we'll see just a few protocol changes, not many. We do have a CPR-induced consciousness protocol, and of course, it just makes sense that that would be ketamine. The dose is 1 mg per kg IVIO. It is the most hemodynamically stable medication that we carry. It's not the best, but it is. It probably is the best, but no sedative, no benzo is perfectly hemodynamically stable. But ketamine is probably will have the least impact on hemodynamics out of any of them. Now, CPR-induced consciousness, what is that? What's when you do about 30 compressions and the patient starts to wake up, and then you stop CPR and they no longer move and they're not in a perfusing rhythm. All right, so that happens. We've seen that even more frequently. A patient that's on dialysis or they're a known hyperkalemic patient, you all should be very familiar and comfortable with treating hyperkalemia at this point. If you have a reason to think hypovolemia, give a fluid bolus. Pneumothorax, if you intubate the patient, then they arrest, well then whatever you did most likely caused the arrest if you did a procedure and then the patient died. So consider misplaced tube or pneumothorax. Opioid overdose. So Narcan, if let's imagine that you're ventilating this patient and then you see them go into cardiac arrest, known overdose, just give the Narcan. It's pretty much low-hanging fruit. It may or may not be helpful, but there are situations, and I've been a part of these, where you go on an overdose and you're unsure if you feel a pulse, so you start CPR and you give the Narcan and then they wake up. Were they really in cardiac arrest? Well, you didn't feel a pulse, right? So technically, yes, but their heart was likely still beating. It was just not beating vigorously enough to perfuse the brain. So those are some special situations. Now, there are more with pediatrics. There's a big paradigm shift from thinking that pediatrics are all that different from adults. And they're not. They're not that different. We can extrapolate our pit crew method to pediatrics, and we've seen this, and it's effective. Instead of the CAB, focus on compressions, defibrillation. With peds, we focus on arrival, airway, so BVM ventilations, then compressions, then defibrillate and drill and give epinephrine. A, B, C, D, E. Minimum scene time interval still applies to peds. However, we will not be terminating patients under the age of 18. For pregnant patients, our entire goal is to make sure the mother survives, and in return, that gives that fetal the best hope of surviving. Now, with pregnant patients with gravid uteruses, uteri, singular, a patient with a gravid uterus, you've got to do something to maneuver that, because there's such a thing as, I think it's called maternal supine hypotension or something like that, where that large uterus with the baby actually compresses the inferior vena cava and decreases blood return back to the heart. So you have to manually displace this to the left. If that's hard or not possible, you can slightly tilt them 30 degrees, but again, that's going to be hard to do good CPR unless you have mechanical CPR device on the patient. Now, if you do have to do CPR on a pregnant patient, then you can go up just a little higher on the sternum than you normally would. And respiratory, if there's a respiratory etiology, asphyxia, like patient was having severe pulmonary edema, COPD, or asthma, then they arrested, number one priority is airway. If it's a drowning, number one priority is airway. If it's a hanging, number one priority is airway. It is airway, breathing, then circulation in those circumstances. If you get a pulse back, which we do quite frequently, thank you, it is keeping that patient from rearresting. If a patient is going to rearrest after ROSC, they're most likely to do it within the first 10 minutes. So when you get a pulse back, that's not necessarily the time to load and go, all right? It's not the time to rush to get off scene because you don't want that patient to catch you with your pistol in your holster while you're trying to move them to the ambulance. So number one priority, finger on the pulse, eyes on the monitor. All right. Do not let them rearrest. Target your O2 sat. Get it slightly above 94%. Don't hyperoxygenate. Don't hyperventilate. That patient's heart is stunned. It has went however many minutes without essential oxygen and other nutrients. All right. So they're likely having some cardiac dysfunction. Aggressive hyperventilation will cause them to rearrest, so still use the hand-heavy ventilation timer. And when you put them, if you put them on mechanical ventilation, the mechanical ventilator, I would lower the minute volume on that. All right. If the blood pressure is low, treat it. Our goal is to maintain the systolic more than 90. Systolic needs to be more than 90. So what am I going to do after I get a pulse back? Well, I'm going to make sure we have perfect ventilation. I'm going to get a 12 lead. I'm going to pre-mix my pressor, get that ready to go. All right. And if I had push dose epi pre-mixed, not only can I treat hypotension, but I can also treat bradycardia because we all know about those epi pulses where they progressively brady into asystole. Let's get that ready to go. 12 lead. And treat seizures. Just follow your other guidelines, right? Bounce around in your guidelines if you need to. If they're having signs of purposeful movements, then use your post-intubation sedation protocols. So if they have obvious STEMI on the EKG, we're going to take them to a PCI center. And then even if they don't have a STEMI on the EKG, we want to take them to a specialized post-resuscitation center. All right. And termination of resuscitation. Now, this should be in line with the memorandum that was released after we realized that, hey, the state does not like us terminating patients in VFib or fast PEA. So the way we've been doing it applies. If they're in asystole, we can terminate if there's no ROSC after 20 minutes in the absence of hypothermia. So what if they weren't initially in asystole? Well, the only requirement is that they are in asystole. All right. Now, you know what? If I've got a patient that's bouncing from asystole to PA or asystole to VFib or VTAC, I'm probably going to want to work them longer anyway. So let's just keep working those until they're persistently in asystole. And then, of course, the criteria that you're accustomed to still applies. So if there's no evidence of neurologic function, what if we're doing CPR and that patient's crying, they're lacrimating, they're moving, they're swallowing? Keep going. All right. If someone on scene says, I'm just not comfortable terminating, something feels off, keep going. All right. There has to not be a pulsatile SpO2 pleth. So what if you decide to terminate this patient and you see a pleth? Now you need to view the SpO2. You need to see it on the screen to know if there's a pleth or not. You can't just put the SpO2 probe on. You actually have to physically see that pleth. I was called to back up a crew because they said, we've worked this patient for a while. They've got a beautiful PEA at a rate of 1 something. This patient has to have a pulse, and we really don't want to take them to JCEMS. So got there. They had the SpO2 probe on, but it was not on the monitoring window. Switched it to the monitoring window. Pause CPR, saw a beautiful pleth. And I'm like, the patient's got a pulse. Let's find one. And sure enough, we found one. All right. And then end-tidal CO2 has to be less than 20. Why less than 20? Well, some of these are to make sure that the patient's dead. All right, meaning there's no pulse, no evidence of neurologic function, no pulsatile SpO2 pleth, and end-tidal CO2 less than 20. End-tidal CO2 less than 20 is a prognosticator. All right, meaning if the entitle is less than 20, then that person's chances of getting a pulse back are extremely slim. And if it's less than 20, it's like almost 0% chance. But if it's higher, if it's 30, 40, hey, this patient, they've got good substrate. Their cells are producing the byproduct of CO2. So there's some metabolic function. Let's keep going longer. Now, there's nothing for, narrow complex PA less than 40. I have lobbied the Kentucky Board of EMS to provide clarification on this, and Dr. Tim Price and a few others on the board were of the mindset that if there are agonal beats, if the patient has agonal beats of 10, 15, 20, then most people would consider that asystole. All right. Now, you need to use your good judgment and this. You need to use your obtain a thorough history. What was the patient's lifestyle like? What's our prognosis like? Is our end-tidal CO2 22, 24? Is it going up? Has there been some kind of improvements? Have there been rhythm changes? Have we been in and out of PEA? All of those things you have to consider. Now, if you choose to do that, you want to call med control. Anything other than that, especially if it's refractory, recurrent VFib, VTAC, do not terminate. This is pretty clear. This is not a gray area. Now, there are situations that one could argue that if we call med control and get orders to not terminate but to withhold resuscitation, call a coroner, and then we're getting those orders based on medical futility. All right, based on medical futility. But that is too much beating around the bush, operating in the gray area. So the most simplest and straightforward thing is if it's a fast PEA or refractory and recurrent VFib or VTAC, do not terminate. We still want to resuscitate them on scene for 30 minutes unless, and this could change, we're working with a facility that will hopefully allow you to take that patient to the cath lab during CPR. If that is a possibility, then you can consider that. I may also consider moving that patient earlier if it was witnessed. We've shocked them 3 or 4 times. They're still in refractory VFib. They have signs of life. Maybe I'm going to call a PCI center that we can transport this patient to and say, I want you to talk to the cardiologist. All right, talk to the ER physician, talk to a cardiologist, and say, I've got a patient that has signs of life. They're young. They have refractory VFib. Their end-tidal is 40. That's a very good sign. This patient is a candidate for intra-arrest PCI with mechanical CPR. Will you take this patient? And they just might. Some physicians, some cardiologists are more aggressive and might just take them. All right. Now, something that I'm not going to cover in great detail, but I think that you all will find this more clear than our previous protocol on trauma arrest. If the patient is 18 or older and it's a blunt traumatic arrest, you can terminate or withhold any blunt trauma patient who is apneic, pulseless, and asystolic on the EKG or cardiac monitor upon your arrival. All right, now I'm not going to go through all the trauma criteria or the obvious signs of death on this, but I thought that you all might like that. And then some key considerations. These are especially useful for like special situations. But of course, something that we have to talk about, and what's most important is when you're deciding on terminating resuscitation or even withholding resuscitation, your focus then should be turned to the families, to the family members of that patient. We should, and we do, we let patients observe our resuscitation efforts as long as they are not interfering with our resuscitation, all right? Because historically what has happened was We show up on scene, we grab the patient, and we load and go, and we whisk them away to the hospital, and we don't communicate to the family. We get to the hospital, and then the family gets to the hospital, and then they're told that, sorry, they're dead, right? The physician talks to him, says your family member, your loved one is dead, and all they know was that we came, we grabbed the patient, took him to the truck, sat there for 15 minutes, then transported to the hospital. So what are they thinking? Well, what did EMS do? What did EMS do to that patient? This is even true of pediatrics. This is even true of pediatrics. If the family sees you working your butt off, doing everything that you can, they are more likely to be reassured than if we just load and go. So that's all I have. I hope that's all I have. I hope that was useful. And as always, let me know if you have any questions. Thanks.